Today I am going to discuss about the urinary bladder cancer. Friends, urinary bladder cancer is a very important cancer because if you detect these patients who have this urinary bladder cancer, and if you detect it in early stages, you can save so many lives. Now coming to the anatomy and the physiology of the urinary bladder. So urinary bladder is made of several layers, starting from the mucosa, which is the innermost layer, to the serosa, which is the outermost layer. In between, after the mucosa, there is a layer called submucosa. Then there is another layer called lamina propria. Then there is a muscularis propria. It is called muscle layer of the bladder, and then finally the serosa. So cancer can arise from any of these layers, but the most common cancer arises from the innermost layer, which is the mucosa. The cells of this mucosal layer are called transitional cells. This transitional cell epithelium, in fact, is not only restricted to the urinary bladder, it extends till the kidney also. In fact, it extends till the prostatic urethra. So any of these extents, this is the total extent, right from the kidney to the prostatic urethra, are actually a risk to develop urinary bladder cancer. So as far as the physiology is concerned, the purpose of the bladder is to store the urine which is being made in the kidney on the speed of 1 ml per minute, and this trickles down and gets collected in the bladder till the bladder capacity is full, which is somewhere between 400 to 500 ml. So after the capacity is full, the bladder prepares itself for the empty. How the cancer forms, these transitional cells, they have some changes because of the various reasons, and these cells, they start dividing very fast without any control and without any check. Now coming to the risk factor, there are various risk factors for this cancer. So the commonest risk factor is the smoking. Smokers have higher possibility to develop urinary bladder cancer compared to the non-smoker. It is the most consistent risk factor for the bladder cancer. Second is the occupational exposure. There are some occupational byproducts which actually stimulates the formation of the bladder cancer, and these industries are dye industry, the leather industry, painting, so plastic, all these industries, there are some toxic products. Because of the exposure with these products, those who are working over there or coming in contact with these toxic products have higher possibility of developing the bladder cancer. Third is the age. It has been that the higher is the age, higher is the possibility of the bladder cancer. So as the age increases, the risk of the bladder cancer also increases. Fourth is the gender. Ratio of male to female cancer is 1.5:1. Coming to the diagnosis, how we diagnose these cancers. So for diagnosis, we have to understand what are the symptoms of these cancers. There are various symptoms. The common one is the intermittent, painless, gross total hematuria. Each word is very important. Intermittent means it is not a continuous bleeding. Bleeding occurs, then it persists, stops, and then recurs. So it is intermittent. Gross means it is a visible hematuria. It is mostly not microscopic. It is a grossly visible hematuria. Total means complete urine. There are various kinds of hematuria which I am not going to discuss further, but in brief, there is initial hematuria, total hematuria, terminal hematuria. So in urinary bladder cancer, the hematuria is total, means the total urine is blood mixed or red right from the starting of the urine till the end. And then coming to its paleness hematuria. Bladder cancer can present with other urine symptoms, for example, dysuria or frequency of urine. There are some specific kind of bladder cancers who actually present like this, and the common one is the TIS2. In this category, the growth occurs in the wall of the bladder, so there is no visible growth. So, and these patients usually present with the frequency or dysuria. Along with that, the patient can have backache or any symptoms related to any other organ if it is an advanced or the metastatic disease. For example, there can be history of convulsion, there can be history of respiratory problems also if the cancer has gone to the lung. So these are the basically the symptoms. Now coming to the diagnosis. So on the basis of these symptoms, the bladder cancer is suspected. Then the next step of the diagnosis is the investigations. Now the investigation, the first and foremost is the urine cytology. The urine is seen under the microscope, and if you pick up or detect malignant cells in the urine, the diagnosis is confirmed. After urine cytology, the next best investigation is the cystoscopy. Cystoscopy is visualizing the urinary bladder and the urethra through a equipment which is called cystoscope. And in this equipment, there is a camera, a light source, and it is actually mounted on a tube, and this is inserted through the urine passage and visualizes the internal anatomy of the bladder. And you can visualize if there is any growth, you can visualize. Simultaneously, you can take the biopsy also. The next is the imaging studies. Ultrasound, CT, MRI. They have their own role for detecting the bladder cancer, but most of the time MRI and CT have a role in staging the bladder cancer. Next is the type of the bladder cancer and staging of the bladder cancer, because the treatment decided on the basis of the type of the bladder cancer and the stage of the bladder cancer. So coming to the type of the bladder cancer, there are various types of bladder cancers, but 90% of the time it is the transitional cell carcinoma, which is called TCC. So transitional cell carcinoma usually arises from the transitional cell epithelium of the urinary bladder and is the commonest one, contributes more than 90% of the urinary bladder cancer. The second is the squamous cell carcinoma. Squamous cell carcinoma is 5 to 6% of the total urinary bladder cancer, and this usually occurs in patients who have some chronic irritating disease of the urinary bladder. That may be a prolonged bladder stone which has been since long and causes some changes in the mucosa of the bladder. So chronic irritation can change the mucosa from the transitional cell to squamous cell. Similarly, if there is a catheter which is there for the since long, so that can also change the mucosa to the squamous cell. So if these kinds of problems are there, and then the tumor which arises from this epithelium is called the squamous cell carcinoma. Third cancer is the adenocarcinoma of the urinary bladder. Adenocarcinoma is basically the cancer which arises from the glandular part of the mucosa. So what happens? These glands, they secrete a product which is called mucin. So these cancers, they actually look is different from the squamous cell carcinoma and the transitional cell carcinoma, and the treatment is also different compared to these squamous cell carcinomas and the transitional cell carcinoma. There is another kind of cancer which is the sarcoma. Sarcoma usually arises from the muscle cell. So But what happens, the adenocarcinoma is 2 to 3%, and the rest of the cancer, for example sarcoma, etc., they have contribution of 1 to 2%. Now coming to the types of transitional cell carcinoma, so these are basically divided into main types. One is superficial bladder tumor, the other one is a deep bladder tumor. Basically this classification is for those bladder cancers who are restricted to the bladder wall. So if the tumor is arising from the mucosa and has not invaded beyond the lamina propria, then it is superficial bladder cancer. Once there is involvement of the muscularis propria, the muscle layer gets involved, then it is called deep bladder cancer. Now we are actually going to discuss is the staging of the tumor. This is the most important part, because the treatment is decided on the basis of the stage of the tumor. So staging is done on the basis of the size of the cancer or size of the growth, which is called T and M. And the second is the grade of the cancer. Now there are various grades, low grade, high grade. In low grade, what happens, the cancer cells, the architecture is maintained as the normal transitional cell. They are almost similar to the normal transitional cell. The only thing is they divide very fast. The second one is the high grade. In high grade cancers, the division is so fast that they don't get opportunity to mature. The significance of this grade is that the low grade cancers, the response against the treatment is better compared to the high grade. High grade cancers are more aggressive and they respond poorly to the treatment. Now coming to the TNM staging. Here basically the staging is performed on the basis of the what is the depth of the tumor. Means if it has it arises from the mucosa, so whether it is extended to the submucosa or lamina propria or muscularis propria, so the T word is to decide depth of the growth. So the first one is the TA. In TA there is a papillary kind of growth which arises from the mucosa and doesn't invade beyond this mucosa epithelium. Second category, which is called T1. In T1, the invasion, the extent of the invasion is submucosa or lamina propria, but it has not extended beyond the muscle part. Now, if the muscle part is involved, it goes to T2. If the cancer goes beyond the muscle cell, then it is T3, and if there is involvement of the surrounding organs, then it is called T4. Similarly, there is N0, N1, N2. That shows if there are no lymph node involved, then it is N0. If there are lymph node involved, then it is N1. M stands for the metastasis. So if there is metastasis to any of the distant organ, then it is M1. Otherwise, it is M0. So coming to the treatment. Now, as I told that the treatment is decided on the basis of the staging. Staging we have already done on the criteria I have just mentioned. So the most common treating modality is the TURBT, Transurethral Resection of Bladder Tumor. In this modality, the tumor growth is resected with the help of equipment which has an assembly of camera, light source and a working element, and is inserted through the urine passage, and the tumor is resected slice by slice, and after that this tumor burden is evacuated. So there is a mechanism and a provision in the equipment itself. This is applicable to those cancers who have not crossed beyond the wall of the bladder. The aim of TURBT is to completely remove the urinary bladder cancer if it is a superficial bladder cancer. The second surgical intervention is the radical cystectomy, where by the help of the open or laparoscopic or robot, the bladder and the surrounding organs are removed and the urine is diverted by making a kind of bladder with the help of the intestine, and both the ureters are joined in the particular newly made bladder, and one end is opened in the abdomen. So this urine from the kidneys, they come and collect over the newly made bladder, and finally it is drained from the opening which is made in the abdominal wall to the external pouch which has been applied over there. Now another modality is the immunotherapy. Immunotherapy is, there are some immunogenic agents. The commonest one is the BCG. What they do, they stimulate the immune cells of the patient and pushes them to fight against the cancer cells. These agents are instilled on the basis of cycle. The commonest one is the BCG. It is instilled on weekly basis. There are 6 weekly cycles, and the installation is very simple. A small catheter is inserted and previously reconstituted BCG solution is injected through the tube into the urinary bladder, and patient is asked to change the posture frequently so that this solution should go in contact with all the corners of the bladder. And after giving this for 6 cycles, then the outcome is monitored. The third is the radiotherapy. This modality is also a local kind of treatment. Now coming to the chemotherapy. Chemotherapy is usually used when the bladder cancer goes beyond the bladder and goes to the different organs or different sites. Then you have to actually give a chemotherapeutic agent intravenously so that it can go in the body and trace and target the cancer cells wherever they are. Now this is the treatment of the bladder cancer. Coming to the follow-up. This is the most important part of the urinary bladder cancer, because the recurrence of urinary bladder cancer is very high. It is 70%. Means if 10 patients are coming to me, I do expect that out of those 10, 7 will come with the recurrence. So there is a follow protocol which says that these patients should be followed on 3-monthly basis, and what is done in each follow, the urethrocytoscopy is done, and if any tumor is visualized, that is resected. If the patient has no recurrence for 1 year, then the modality changes to the 6-monthly. So 6-monthly follow-up is done similar to the 3-monthly for the next 2 years, and after that it is an annual. The recommendation is that if after 5 years nothing happens, then you can release the patient, but we recommend that no, that should be done lifelong on annual basis. So this is what all about the bladder cancer.